resting membrane potential. And as we just reviewed, it would be there, negative resting membrane potential. So up here, would be zeros. Okay. And that would be due to our sodium potassium leak channels, our sodium potassium pumps, and our protein negative charges. What is that called?
Graded.
A graded potential. And that would be due to what type of channel? Ligand-gated channel. So again, in this case, the cell is depolarizing, but ligand-gated channels, if they allow chloride into the cell or potassium to leave the cell, would cause a repolarization or a hyperpolarization, which would make it, of course, more difficult to reach this point. That point right there is identified as threshold potential. And in this case, it's caused because of the ligand-gated channels. All right. If we're talking about the formation of action potential after action potential, then it would be voltage-gated channels opening, allowing that to occur. And we wouldn't see this graded potential. We'd see this occurring as soon as the current reached it. We wouldn't have to see that graded.
What was the problem when you could see it just keep jumping like that when there was multiple?
That was multiple triggers, multiple activation, stimulation of a muscle cell before it could relax. You're talking about the trip? Yeah. But that was looking at not the current, but the contraction force. Okay, and both of these, both the depolarization and the repolarization, action potential. Due to what type of channel? Voltage-gated. In the case of skeletal muscle and neurons, it would be sodium and potassium. And then with hyperpolarization, that was due to the potassium voltage-gated channels staying open a little bit longer, and then the potassium pumps recovering. Okay. Pardon?
Is it both repolarization or hyperpolarization?
Well, when we go below resting membrane potential, then we call it hyper. So this is due to open potassium voltage-gated channels and the recovery by sodium potassium pumps. Okay? So that was about a week of lecture in Bio 430 in about half an hour. So again, if this doesn't seem familiar to you or you want to read about it a little bit more, just go back to your textbook and reread the material on that. Miriam has it both in the membrane chapter and in nerve and muscle. Now in the heart, we have two different types of muscle cells. The earlier illustration that I talked about were of the contractile cells that we'll talk about towards the end of lecture. The Anybody in here signed up for the heart transplant case study? That's a fun one. The woman is in her early 30s. She and her husband are mountain climbers. And she had a goal of climbing the highest mountain on all continents. And she'd already done, I don't know, several, 4 or 5, when she got a virus that damaged her heart. And she developed cardiomyopathy where the heart gets bigger because it's too weak to contract, and it just gets stretched out more and more and more, and that just makes it weaker and weaker because it can't push the blood through. And she ended up getting a heart transplant. Her goal was still to climb mountains. And with a heart transplant, they don't reconnect the nerves. So she doesn't have sympathetic and parasympathetic innervation of her heart. The heart, of course, contracts. So, if you, in physiology classes that I've taught, we've taken large bullfrogs and maybe turtle hearts, so that's a little bit more difficult because you have to drill a hole in the turtle shell. And you can take the heart out, place it in a beaker of physiological saline with the appropriate ions, and it will beat for at least 45 minutes until it runs out of ATP. So there's, of course, no innervation. So the specialized muscle cells, we call autorhythmic cells, depolarize on their own. And that creates the pacemaker, if you will, that triggers the depolarization of the actual contractile cells. So the role of the nervous system is to increase or decrease that rate. The cells that are the actual pacemaker cells are located just below the superior vena cava in the wall of the right atrium, and depolarize at the rate of about, we'll talk about this when we talk about ECGs, depolarize at the rate of about 100 times a minute. That's not your normal heart rate. Okay? For most individuals, it's around 70. You'll see 70 to 72 used as the average heart rate. And this is the influence. What's the rest and digest component of the autonomic nervous system? Sympathetic or parasympathetic? Parasympathetic. And so that slows the heart rate down. So instead of 100 times a minute, it's about 70 to 72, okay, unless other factors are coming into play. That triggers a current that leaves the pacemaker cells, the autorhythmic cells, and travels in a wave-like sequence through gap junctions, through the atrial muscle, and from the apex of the ventricles back up towards the valves. All right, we'll talk about how that occurs when we look at the concept of an ECG. So we have those two different groups of cells, the autorhythmic cells, which are highly modified. They're not nerve cells. They're highly modified contractile cells that don't have much actin or myosin left. And a lot of glycogen in them, but they're not contractile. So that's the pattern that we see up here on the board. Are for the autorhythmic cells, meaning they set, auto meaning self, they set their own rhythm based on their depolarization. Now, what is lacking of the different thresholds that we talked about? What is lacking from this image? Exactly, resting membrane potential. So those autorhythmic cells do not demonstrate a resting membrane potential. As soon as they repolarize, they start depolarization again. So when we look at this diagram, first of all, I want you to recognize this diagram as the electrical pathway of autorhythmic cells. I want you to recognize, well, diagram is up on the board. So these are autorhythmic cells, cardiac. And when we look at the contractile cells in a few moments, they're going to look like that. So cardiac contractile cells. And then I want you to recognize what I just drew on the board. As skeletal muscle cells. So, first of all, be able to recognize and identify those components. And then, remember how I went through with the skeletal muscle cells when we talked about the resting membrane potential and what characteristics, what types of channels created that potential, and what the rated potentials were. So be able to recognize those for the other components as well. What types of channels are open or closing, and what types of potentials are created. And that's what we're going to go through next. Okay, so we just did it for skeletal muscle as a review. And now we're going to look at that for autorhythmic cells, and then we'll do it for the cardiac contractile cells. So these autorhythmic cells are located in specific regions of the heart, known as the conductive tissue. So if we look at our heart, this looks like a heart. So first of all, where the superior vena cava comes in, we have the sinoatrial node. And that's going to be formed of autorhythmic cells. Then, in the lower right atrium, near the interatrial septum, we have the atrioventricular node, or the AV node. We have a bundle of conductive tissue going from the atrioventricular node to the interventricular septum. And that's identified as the old name is bundle of His, but now we call it the AV node, AV bundle or atrioventricular bundle. And we'll cover this again when we talk about the ECG. A pair of bundle branches. But it's easier if I do it in color. And then these travel up the ventricular wall. Even cardiac contractile cells are autorhythmic. They don't depolarize at the same time, and they don't depolarize as fast. So SA node depolarizes the fastest, so that's why it's called the pacemaker. Okay. AV node is slower than the SA node. The bundle's even slower yet. So this is the one that depolarizes about the rate of 100 times a minute. This is about 60 to 70, 40 to 60. Again, we'll go over that specifically. Individual contractile cells, about 15 times a minute. So that's what ventricular defib is. Each ventricular muscle cell is depolarizing on its own, and instead of contracting in a rhythmic fashion, the muscle just quivers and doesn't completely create a stroke volume. So this is the location of those autorhythmic cells. Again, when we talk about ECGs at the beginning of lecture on Tuesday, we'll go over those. But I just want to give you an idea of where we find these cells. Okay. So autorhythmic cells to threshold, and we'll talk about what types of channels allow that to happen. When threshold is reached, instead of sodium voltage gated channels open, calcium voltage gated channels will open. And this is our action potential. We'll go through these step by step. The calcium channels close, the potassium channels open, the cell repolarizes, and this repolarization, all right, then starts again with a slow depolarization. And this occurs about 100 times a minute in an unregulated SA node, channel atrial node cells. And we'll talk about what happens to modulate that to get a faster heartbeat and to get a slower heartbeat. Back to acetylcholine neurotransmitters that we were looking at. So about 30 years ago, a description of that, what triggers the beginning of that slow depolarization, was described as a funny current. This is a new slide that I made up this morning. Talk about it, but it's not in your previous slides. And the funny current is what, may I erase this diagram here of the pacemaker cells? The funny current is what triggers this slow depolarization. It is activated by the hyperpolarization occurring here. So this hyperpolarization is very low negativity. Usually is triggered at about, the funny current will trigger at about a minus 50 millivolts. And that will trigger this funny current. The reason it's called a funny current is it's because it's weird. It's not funny in that ha-ha, it's just funny in that it's weird, it's transient. Okay, so it's triggered by voltage, by that hyperpolarization. But it can also be triggered by the activation of cyclic AMP. This is where norepinephrine comes into play. So I'll come back to that. I'm not going to talk about it right now, because I want to look at the standard autorhythmic potentials before we talk about how it's changed. Okay? So here we see another view, and it's due to this first, this funny current is triggered by, we have sodium leak channels that are always open. Okay? And slowly closing potassium channels. And then the funny current channel. Which are open to both sodium and potassium, which are going in opposite directions. Okay? If it was just sodium, the cell would depolarize faster. Since potassium is leaving, that kind of slows it down. So if it was only sodium coming in, we would see this. Because potassium is also leaving, that helps to slow it down. Okay? So it's a weird kind of channel that's open to both.
What's the I?
It usually stands for inhibitory. It's just the way this funny channel is referred to in the literature. Okay. This is a scary looking diagram with all the lines on it. So let me go through it with you slowly, and it will make a little bit more sense. So what we're talking about is this line right here, okay, which it looks really short there. We're talking about this cardiac pre-potential. This is a graded potential. Okay, so this is a graded potential here. As we go through those components. And again, remember I said I want you to understand the relationship to the skeletal muscle, what's going on. So we have the sodium-potassium pump. So that is referring to this structure here. So I put a number 1 up there. And that's not a resting membrane potential, but that's moving sodium out and potassium back in. Okay. We have a leak sodium channel, that's this one here. And we have the voltage-gated sodium channels that are closing and allowing this to occur. What's not in that diagram is that funny channel that's open to both sodium and potassium. It wasn't in the diagram that I copied these out here. Okay, but both of that will be up there as well. So think of an hourglass where sand is slowly dripping from the top to the bottom of the hourglass. Instead of sand, it would be sodium ions. Okay? So sodium ions are slowly leaking into the cell. Potassium ions that would be leaving are leaving less and less rapidly because the voltage-gated channels are closing. So more of those potassium ions are being kept within the cell. So both of those are adding to that slight rise of depolarization. More positive ions are in the cell. And then we would have those funny current channels are present as well. Okay? They will open, it shows -40, they actually open here at about the -50 to 55. So they start this first upward component here. So let's add in the funny current channels here.
Can we get the new lecture slides? Or are they online? Or?
I can put them online. I just was modifying them this morning. And that's important because of the role of norepinephrine and acetylcholine. All right, because what norepinephrine does is it makes the funny channels open earlier. So let's come back to that point. So here's our repolarization, and we hyperpolarize. The funny channels normally don't open until about -50 to -55. All right. What happens when norepinephrine binds, and its effect is the funny channels, the cell doesn't have to hyperpolarize as much. The funny channels will open earlier, so instead of coming down here, we'll start to rise again. So it doesn't take as long to get to that point, so when we rise earlier, guess what happens? Action potential occurs earlier. We have more action potential per minute. We have a faster heart rate. Okay, so I'll get back to that point when we talk about the effect of norepinephrine. So we're just looking at this first point here, right? So what you would add to your explanation here would, this is a graded potential, and it's going to be due to the sodium-potassium pumps. The potassium leak channels, either the sodium leak channels, and the funny current channels that are primarily for sodium, but also for potassium. Then